Hello everyone, welcome to Patho Excellence. Today we are going to discuss a topic Pediatric CBC Interpretation Approach from Newborn to Adolescent, in which we will going to discuss hematologic values in the healthy fetus, neonate and child. So before we start, why is Pediatric CBC difficult? Let's see one scenario. A 2-day-old term neonate, and here HB is 19.4, WBC 24,500, MCV 114, NRBC 6 per 100 WBC, neutrophils 68%. So here how many abnormalities are present? Let's see. HB is raised, so whether it is polycythemia, count is high, so whether it is leukocytosis, MCV suggests macrocytosis, or left shift due to high count and neutrophilia, or NRBCs. So from these values only it can be in abnormal result. But if we see the age of the patient, this is a completely normal CBC for a healthy term newborn, and that's why interpreting a CBC in children is completely different from interpreting an adult CBC. Hemoglobin level, WBC count, MCV that appears abnormal in an adult may actually be perfectly normal in a newborn or infant. So in this lecture, we will learn how hematologic values change from the healthy fetus to the neonate, infant, child and adolescent, and discuss the essential points to review before evaluating a peripheral smear. So, the learning objectives include interpret pediatric CBC age-wise, avoid common diagnostic errors, recognize physiological hematological changes, correlate CBC with peripheral smear, and decide whether CBC is normal or pathological. Now let's see first of all definition of age groups. So premature neonates, term newborn which is 0 to 28 days old, infant 1 to 12 month, toddler 1 to 3 years, preschool 3 to 5 years, school age 6 to 12 years, adolescent is more than 12 years. So, never compare a neonate CBC with adult reference ranges, because we are having adult reference ranges in our cell counters. So, let's see first hematologic changes during fetal life. So, 3 weeks of gestational age will have primitive erythropoiesis begins in yolk sac. At the 6 weeks age, liver becomes the major hematopoietic organ. 10 to 12 weeks, spleen contributes to hematopoiesis, and 20 weeks onward, bone marrow gradually becomes the major site, and after or at birth, bone marrow is the principal hematopoietic organ. So, during intrauterine life, there is low oxygen tension, high erythropoietin, active erythropoiesis and high hemoglobin F. And after birth, oxygen tension rises dramatically, erythropoietin production falls rapidly, bone marrow slows erythropoiesis and HB begins to decline. So, if we see physiologic characteristic, predominantly HbF is there, high erythropoietin activity, active erythropoiesis, numerous immature cells in circulation, and higher MCV than adults at that stage. Now let's see normal RBC parameters in the term neonate. So, normally at this first day of life, 14 to 22 gram per deciliter hemoglobin, 45 to 65% hematocrit, RBC count 4 to 6.5 lakh, MCV 98 to 118 femtoliter, MCH 31 to 37 picogram, MCHC 32 to 36 gram per deciliter, RDW 15 to 20% and RC count is 3 to 7%. So, this is the normal range in the term neonate for RBC. So, let us see peripheral smear. Here you can see in peripheral smear macrocytes. You can identify macrocytes. Then mild anisocytosis. So, some of the cells are small, some are the macrocytic, right. So, the mild anisocytosis. Polychromasia. These are the polychromatic cells. You can see the color difference from these normal RBCs. So, they are mild magenta and pink color. So, mixture is called polychromasia. Then occasional target cell. So, here you can identify target cells. Then NRBCs. So, here these are the normoblast. We have to count normoblast, total number of normoblast per 100 WBC. And this is physiological in term neonate. So, these normoblasts are present generally up to 10 NRBCs per 100 WBC in term neonate. Now, let us see WBC parameters. So, here it is 9 to 30 thousand total WBC count, which is normal for term neonate. So, whenever you get high count, do not consider as leukemia reaction or leukemia. Now, neutrophil 50 to 70%, lymphocytes 20 to 40%, monocyte 2 to 10%, eosinophil 1 to 4% and basophil 0 to 1%. So, physiological neutrophilia occurs immediately after birth due to labor stress and catecholamine release. So, this is the value you have to keep in mind when you evaluate CBC of newborn. Now, platelets. So, platelet normal range for term neonate is 150 to 450 into 10 raised to 9 per liter and MPV is 8 to 12 femtoliter. Now, what are the changes during the first week of life? So, hemoglobin remains high but begins to decline. Hematocrit gradually decreases. Reticulocyte count falls. NRBC disappear by 5 to 7 days. So, normally if you are getting CBC after 7 days, NRBC will be absent, right. WBC count decreases. So, first physiological leukocyte crossover occur at 4 to 5 days. So, what is crossover? Means at the time of birth or at the first day of life there will be neutrophilia. But at the 4 to 5 days when neutrophils and lymphocytes become approximately equal. So, neutrophils are decreasing and lymphocytes are increasing at the 4 to 5 days of life. Now, during infancy, where term infant will have a 9 to 11 gram per deciliter at 6 to 12 weeks, right. So, this is normal and Preterm infant will have a 7 to 9 gram deciliter at 4 to 8 weeks, right? So this is physiological process and this does not require treatment. So whenever you get sample at the age of 6 to 12 weeks, term infant, if he or she having 9 to 11 gram hemoglobin per deciliter, it is physiological, right? So physiological anemia of infancy, which is which does not require treatment, and it is occurring because oxygen saturation increases after birth and erythropoietin production decreases, as well as RBC lifespan is shorter in neonates, approximately 60 to 90 days, which in adult it is 120 days. Now CBC at 6 months of age. So parameters, if you see, it is HB 10.5 to 13.5 gram per deciliter, RBC count 3.8 to 5.3 into 10 raised to 12 per liter, hematocrit 33 to 39%, MCV. Now you can see MCV is decreased 70 to 85 femtoliter, and reticulocyte count is decreased from 3 to 7% to now 0.5 to 2%. Now in childhood, so at the age of 1 year, HB 11 to 13, 70 to 85 MCV, and WBC count 6 to 17,000. Now 2 to 6 years, there 11.5 to 13.5 MCV upon MCV around 87, WBC count 5 to 15,000. 6 to 12 years of age, HbA raising to 15 gram per deciliter, MCV attaining adult range 77 to 95, WBC count up to 13.5 thousand, and in adolescents 12 to 16 in girls, 13 to 17 in boys, MCV 80 to 96, and WBC count is nearly 4.5 to 11,000, which is near about adult range. Now let's see differential leukocyte count changes in different age group. So we have seen crossover. So at birth neutrophils are predominant, where 6 to 70% neutrophils are there and lymphocytes are 20 to 30%. Now first crossover. So at the age of 4 to 7 days, neutrophils and lymphocytes are almost equal, right? So neutrophils are decreasing, lymphocytes are increasing. So 45% approximate each of neutrophil and lymphocytes are seen. 6 months to 4 year, predominant cells are lymphocytes, which are 50 to 70%, and 20 to 40% neutrophils. And at the age of 4 to 6 years, again second crossover is there, where both neutrophil and lymphocytes are equal approximately, and more than 6 years to adulthood, neutrophils are predominant, means 50 to 70% neutrophil, and lymphocytes 20 to 40%. So always remember first and second crossover while you are interpreting this CBC in pediatric. So now let's see platelet values throughout childhood remain same either in newborn or adolescent. It is 1.5 to 4.5 lakh per cubic mm. So it is stable across all age groups. Now normal peripheral smear by age, if you see, in newborn, you will have macrocytes, polychromasia, mild anisocytosis, occasional target cell, and NRBCs. At the age of 1 month, few NRBCs, decreasing macrocytosis. 2 to 6 months, there is physiological anemia and lymphocytosis. 1 to 5 years there will be relative lymphocytosis, and at the age or more than 6 years adult like smear will be there. Now hemoglobin fraction by age, if you see, HbF is more than 90% in fetus, 60 to 80% at birth, less than 5% at the age of 6 months, and less than 1% in a adult. So accordingly, HbA is very low in fetus, 20 to 40% at birth, more than 90% at the 6 month of age, and 90 to 95 to 98% in adult. HbA2 absent in fetus, less than 1% at birth, 2 to 3% at the age of 6 months, and 2 to 3.5% in adult. So remember, HbF you can find up to 6 months of age, but the value varies between fetus at birth and 6 months of age. Now let's see MCV trend age related. What are the changes? So in cord blood, normal MCV is 105 to 115 femtoliter. Term newborn or up to 7 days, there is 98 to 118. At the age of 1 month up to 112, 2 month 106, 3 to 6 month 74 to 108. But 6 month to 1 year it is 70 to 85. So up to 3 to 6 month MCV can be showing macrocytic picture. It is because active fetal erythropoiesis and transition from fetal to postnatal hematopoiesis. So newborn will have always high MCV, and this is normal finding and does not mistaken for megaloblastic anemia. And 1 to 2 years to 6 to 12 years there will be 77 to 95 femtoliter, and in adolescent 80 to 96 femtoliter, which is adult range. Now NRBC value, whenever we see peripheral smear, we must count the normoblast per 100 WBC count, and if term newborn is there at that day of birth, there is 0 to 10 NRBC per 100 WBC, but up to 20 per 100 WBC may be seen after birth stress. In preterm newborn, 0 to 25 NRBC per 100 WBC or even higher in very preterm infant can be there. If you see the smear after 24 hours of birth, there is rapid decline and usually less than 5 to 10 per 100 WBC is normal. 48 to 72 hours, usually 0 to 5 NRBC per 100 WBC. 5 to 7 days NRBC absent or rare, and more than 1 week normally absent NRBCs. So what are the important points you have to remember? A few NRBC in first 3 to 5 days are physiological, but persistent NRBCs beyond 7 days require evaluation for hypoxia, hemolytic disease of the newborn, sepsis, severe anemia, congenital heart disease, or bone marrow stress. So NRBC count is very important whenever we see peripheral smear picture of pediatric patient. And in older infant and children, any NRBCs are abnormal and warrant investigation. Now, after understanding and seeing all the parameters in normal fetus, newborn, and children. Now, what is the approach before looking at the peripheral smear? So, first step, know the child's age, because the age determines normal HB, RBC, hematocrit, and all other parameters here. And second step is identify or no go for clinical information. So, before opening the smear, ask birth history, because prematurity, low birth weight, NICU admission, birth asphyxia, twin pregnancy, delayed cord clamping, even maternal diabetes, all these influence polycythemia, NRBC count, neutrophilia, and thrombocytopenia. Maternal history is important. You have to rule out anemia, iron deficiency, B12 deficiency, folate deficiency, autoimmune disease, hypertension, preeclampsia, HELP syndrome, gestational diabetes, any infection, drug intake, or because this disease directly affects neonatal CBC. Now, feeding history is also important, because whether the child is on exclusive breastfeeding, formula feeding, or mixed feeding, because breastfed infants develop physiological iron depletion after 4 to 6 months. And development in mental history is also important, because poor growth suggests nutritional anemia or any hemoglobinopathy, bone marrow failure, or chronic disease. Now, family history, always ask for thalassemia or any hemolytic disease like sickle, G6PD, or hereditary spherocytosis, Fanconi anemia, or congenital neutropenia. Drug history including chemotherapy, antibiotics, anticonvulsant, any malarial, steroid, immunosuppressant, all should be asked if mother is on any treatment, because these alter CBC significantly. Now, always go for a history about recent illness like viral infection, bacterial, COVID, dengue, malaria, typhoid, or sepsis, and transient cytopenias is common in this recent illness. Now, step 3, once you have received sample with all the history, confirm sample quality. Many pediatric CBC abnormalities are pre-analytical. So check whether it is taken in correct anticoagulant tube, proper mixing is there or not, clot or present, or hemolysis is present or not, adequate volume is there or not, and correct patient identification, and whether the sample is heel prick sample or venous sample, because what are the problems in heel prick samples? It may show hemoconcentration, platelet clumping, RBC distortion, and dilution with tissue fluid. So after all this, the next step is CBC parameters to review before peripheral smear examination, which is A, B, C, D, E before PSCM. So A means age and gestation, whether patient is term, preterm, neonatal age, or because age specific reference ranges are important. Second, go for blood counts, what is the amount of HB, HCT, RBC, and all parameters. C for cell indices, look for MCV, MCH, MCHC, RDW, reticulocyte count. D for differential and data flags. E for examine smear. So correlate CBC with RBC, WBC, and platelet morphology. So this is the checklist where systematic CBC interpretation you can go for starting from patient age to all the RBC values, WBC values, and look for analyzer flag, RBC histogram, and WBC scattergram. So here you can see what to review, what is normal, what is abnormal, and what is peripheral smear correlation. So take a print of this checklist and always go through this chart whenever you see CBC of pediatric patient. This is again a same features which is given in checklist. So go through in this table form and you can learn many different points. Now step 5 is correlate analyzer flags with peripheral smear finding. Analyzer flags are warning signals generated by automated hematology analyzer, and they indicate that abnormal cells or technical issue may be present and require manual verification on the peripheral smear. So these are the different types of analyzer flag like blast or NRBC or immature granulocyte, atypical lymphocyte, platelet clumps, giant platelet, RBC agglutination, and WBC scattered gram abnormal flag. So this will give you idea about possible cause of this flag and what to look for peripheral smear to diagnose the pathology. You go through this flag because these flags uh, never validate without examining the peripheral smear. It detect abnormalities, but morphology confirm the diagnosis. So ultimate answer is peripheral smear examination, but yes, we have to look for what the flag is suggestive of. Another step is review histogram before finalizing the CBC report, because histogram provide graphical representation of cell size and distribution, and they often detect abnormalities before they are obvious on the smear. So RBC histogram, if it is normal bell shaped curve, normal RBC population, left shift microcytosis, right shift macrocytosis, broad base means increased RDW and anisocytosis, double peak suggests post transfusion or any therapy, iron deficiency treatment, and sideroblastic anemia. Platelet histogram, where giant platelet clumps or microplatelets in the form of broad curve, irregular curve, or small peak respectively, and poor separation from RBC, where very large platelets or RBC fragments may be seen. And WBC scattergram, where normal clusters where normal leukocyte distribution is there, additional abnormal cluster like blast or abnormal cells, any atypical lymphocytes or reactive cells where expanded lymphocytic area may be seen, and whenever infection, sepsis or leukemia, there is increased immature granulocytic area. This histogram and scattergram is a vast topic, and we will discuss in detail all the interpretation of histogram and scattergram in next lectures. So here the golden rules of pediatric CBC interpretation include: first, always identify the patient exact age and gestational age. Never apply adult reference ranges to newborns or children. Third is recognize physiological neonatal polycythemia and macrocytosis. Understand the mechanism of physiological anemia of infancy. Learn the two physiological leukocyte crossover, neutrophilia to lymphocytes predominant and lymphocytes to neutrophilia predominance. Interpret NRBCs according to postnatal age. correlate analyzer flags with peripheral smear findings, review histograms before finalizing report, and always integrate CBC with clinical history because it is a must. Distinguish developmental physiology from the true hematological diseases, right? And these are the tables, and all the reference values are taken from all these reference books. And once you know how these different parameters are there at the different ages in a pediatric patient, you must go for history, age, indices, and histogram before evaluating peripheral smear examination, because following this systematic approach will improve diagnostic accuracy and help distinguish physiological developmental changes from true hematological disorder. So if you found this lecture helpful, please like, share and subscribe to support this channel. And in next lecture, we will see hematologic values in small for gestational age versus term neonate and preterm neonates in detail. Thank you for watching, and I will see you in the next pathology lecture. So keep watching.